join you today to talk about clinical manifestations. I know over the course of this morning you've already heard a lot about clinical manifestations. I'll try to talk about some other aspects and shed some more details that might be helpful. And here we go. The first thing I can't emphasize enough is that you have to suspect the diagnosis, or you'll never detect carcinoids early, and every speaker and everybody who's here is totally aware of that. When you hear hoofbeats and think of horses, you have to also, somewhere in the back of your mind, think about the zebras. You can't do the confirmatory laboratory and radiologic studies if you don't suspect the diagnosis, so you have to suspect it. The most common early symptom of gastrointestinal carcinoids is nonspecific abdominal pains, as Dr. Warner mentioned earlier today, often misdiagnosed as irritable bowel syndrome, and often these symptoms last for 10 years or more before somebody finally gets around to doing the proper test. If it doesn't occur to you about what's going on, though, the test won't be done. Intestinal carcinoids often present with partial small bowel obstruction in its early stages, being a little bit tricky for some people to diagnose. Spasms of cramping, abdominal pain, vomiting, bloating, and if it gets too severe, intermittent cessation of bowel movements as the obstruction worsens. Often, by the time people are diagnosed, liver metastases are already present, and as a result, people have symptoms of carcinoid syndrome, which, as you heard, in midgut carcinoids typically occurs in the setting of liver metastases, and that's when diarrhea and flushing become prominent. About 20% of patients have been presenting with right-sided heart failure, with edema, ascites, pleural effusion, severe fatigue from the tricuspid and pulmonic valves not functioning properly from fibrosis of the heart. This is a classic slide of Aaron Vinnick showing the white line here to give you an idea about what has been the natural history of carcinoids for many years, where people often show up with a proper diagnosis when carcinoid syndrome already occurs with flushing and diarrhea. By then the tumor has been growing for 10 or 12 years. It's grown through the intestine, it's spread into the liver, and disease is very advanced. When you suspect there might be a diagnosis of partial bowel obstruction, it's a little bit tricky to find out what's going on, because a gastroenterologist might do a colonoscopy and say everything is fine, and then do an upper GI endoscopy and say everything's fine, and that's because the tumor is not in the colon and it's not in the stomach, it's in the small intestine, in between, where regular scopes don't fit very well, and diagnostic studies are often not available. There are several things that can be done. The gold standard is becoming a technique called double balloon push endoscopy, where you can actually put a scope inside the small intestine, for example, through a colonoscope, and scope out the small intestine with two balloons blocking the small intestine fluid and an observation chamber between. And you can make biopsies and you can see what's going on. The other very valuable technique is called wireless capsule endoscopy, where you swallow a little pill, and within that little pill is an underwater digital camera with a wide-angle lens, a strobe flash, a radio transmitter, and everything that you can imagine to give you nice pictures and transmit it to a memory on your belt that then gets uploaded into a PC later on in the day. You can do endoscopic ultrasound, particularly valuable for tumors that are involving the pancreas. You can also do endoscopic ultrasound to look for rectal carcinoids, although those are usually already diagnosed by the time you end up doing ultrasound. But pancreatic neuroendocrine tumors often are found initially on endoscopic ultrasound. And there's a technique known as CT enterography, which is a small intestine equivalent of virtual colonoscopy. It's a way to do a CAT scan at the same time you're having your regular CAT scan. You can do it with a special technique to show the small intestine much more clearly. This is a picture of a piece of small intestine that has carcinoids. And as you can see, and as Dr. Warner pointed out, 25% of the cases have multiple tumors. These are multiple tumors. However, they're all small enough that you won't see any of them on a regular CAT scan. You won't see any of these on a colonoscopy because the colonoscope doesn't get that far. And you'll miss these tumors, even though there are lots of them, and some of them are already causing obstruction, unless you do the proper test. for looking for metastatic disease in the abdomen, liver metastases, nodal metastases. The MRI or triple phase CAT scan are the best tests we have. An MRI is fantastic. Octreotide is a very, very good test. Will complement the MRI. It looks at things differently. It looks at things by biologic activity in the MRI or a triple phase CAT scan by its anatomy. A traditional CAT scan is not as good as a triple phase CAT scan or an MRI. This is a picture of a liver metastasis on MRI. You can see very clearly what the anatomy looks like. This is a picture of a CT enterography of multiple tumors. The arrow's pointing to one of them in the small intestine. And with doing a non-invasive test, you can often see little tumors. But you don't have the ability to biopsy tumors like you do with the endoscopic procedure, double balloon endoscopy. This is a picture of an octreotide scan. The liver metastases are lit up white. It has to be done with proper technique because the liver itself will look very white early on in the study. And you'll be hearing more about optimum means of doing this type of test later on in the meeting. Dr. Oberg will be speaking later on also, and his colleagues, about new kinds of PET scanning techniques, which Dr. Woltering alluded to also, which are much more sensitive than PET scanning techniques currently available in the United States, and will show very tiny metastatic tumors. Okay. We heard earlier this morning about some aspects of carcinoid syndrome. I'm going to emphasize just a few key features and talk about them a little bit to give you an idea. The first of these things that we're going to emphasize are going to be some of the common symptoms: flushing, diarrhea, valvular heart disease, wheezing, pellagra. And as you saw, there are actually multiple somewhat minor manifestations, but other things can happen as well when people have carcinoid syndrome. Okay, first thing is flushing. When is a red face a sign of cancer? That's the question. Okay? What is flushing? So flushing is attacks of red skin. It can be associated with burning and warmth. The redness is typically most prominent on the face and neck, and in bad cases will extend to the trunk, abdomen, elsewhere, and it has to be distinguished from chronic red skin. There are a lot of people who have chronic red skin and have had it for the last 25 years, and if they give you a history that they've looked like this all their life, it probably is not redness caused by the carcinoid. The skin looks red because there's an increased blood flow in the skin. That's why the skin becomes more red. Okay? It doesn't get dyed with a red dye. There are vasodilator substances released by the carcinoid. Peptides, amines are released that cause dilatation of blood vessels in the skin. The blood vessels immediately beneath the top surface of the skin become engorged with blood, and they look more red. The cheeks are typically the first thing to flush because the blood vessels in the cheeks are very close to the surface. The blood vessels are wider in the cheeks than in other parts of the body, and the cheek skin is very thin, so the cheeks are the first place to turn red. And this is true in carcinoid, and it's true whenever people turn red, which is why blushing is on the cheeks and menopausal flushing is on the cheeks. That's what happens. So this is carcinoid flushing. Carcinoid flushing is typically, for a midgut carcinoid flush, is typically not associated with profuse sweating, like menopausal hot flashes, or maybe in Canada they're called hot flushes. Okay? But are typically so-called dry flushes. However, foregut carcinoids sometimes make a lot of histamine, and sometimes in stomach carcinoids, for example, you could have sweating. So it doesn't absolutely rule out a carcinoid if you have sweating, but a midgut carcinoid, usually not. Carcinoid diarrhea is a secretory diarrhea, lots and lots of water pouring out into the intestine. The stool volume is typically large, more than 1 liter a day of stool. The diarrhea persists even when people are fasting, for example, if they're on IV fluids. like Dr. Woltering's discussion of a VIPoma in the hospital with 10, 12 liters a day. You keep pouring in the IVs, and you're not feeding anything by mouth, and the diarrhea doesn't stop. That's a special kind of diarrhea, secretory diarrhea. And when you look at the electrolytes in the diarrhea, it's similar to what you find in the blood. You don't have the so-called osmotic gap. Okay, carcinoid heart disease, another very important manifestation of carcinoid syndrome, caused by fibrosis that affects the heart valves. You get narrowing of the heart valves, and the valves also malfunction and leak. It's a very simple thing to diagnose by getting an echocardiogram, but you have to think about it. And I see people sometimes coming in the office with a belly full of fluid, massively distended legs, jugular veins that are bugged out so far from blood shooting up backwards from the heart into the jugular veins, and nobody thought to get an echocardiogram. It's a simple everyday test, easy, inexpensive, available anywhere in the most remote communities, and right away you can see the pulmonic valve and tricuspid valve, the tricuspid being the most common, are severely leaking. That's the most common thing, or you can get narrowing. Tricuspid valve involved in 90% of the time, pulmonary valve in 50% of the time. Most patients who have midgut carcinoids have liver metastases, because you typically don't get carcinoid syndrome in midgut carcinoids unless you have liver metastases. But as you've heard, there are cases of ovarian carcinoids and other kinds of carcinoids where you can get carcinoid syndrome in the absence of liver metastases. Serotonin levels are almost uniformly high in carcinoid heart disease. That's one of the hallmarks, and associated urinary 5-HIA is high. Left heart can also be involved, left heart meaning the mitral valve, the other side of the heart, the aortic valve. But this is less common from carcinoids, except for occasional cases of lung carcinoid that cause carcinoid syndrome, or some people have a leakage in the heart where blood is flowing from the right side of the heart to the left side of the heart because of a congenital hole in the heart, like the so-called patent foramen ovale. You can get fibrosis not only in the heart, but you can get it everywhere in the body. You can get mesenteric and retroperitoneal fibrosis, which means that you have lots and lots of scar tissue in the abdominal cavity. This is a surgeon's nightmare, because the tumors often start in the abdomen, and they're surrounded by so much fibrosis, the intestines get all stuck to each other, they get stuck to everything else, tumors get stuck to everything, and it can lead to bowel obstructions and sometimes lead to multiple bowel obstructions. So this is what we mean by peritoneal fibrosis. You can also get retroperitoneal fibrosis. This means fibrosis, scar tissue formation in the tissues right behind the abdominal cavity, in the deep part. This is where the ureters live, the tubes that come out of the kidney, and commonly cause ureteral obstruction when you get a lot of fibrosis in that area. And if it is present, urologists can often put a little tube of plastic in the ureter to reinforce it and hold it open, known as a stent. You can also have problems with mesenteric vessel occlusion and lack of blood supply to the intestine, so-called bowel ischemia, as a result of this scar tissue formation. And this is something which can progress to become a surgical emergency. It can progress to be an emergency that cuts off blood supply to your intestines, and the intestines can die in the end stage of this process. Before you get that far, you want to have a really good surgeon who knows how to operate on these things, take them out to the greatest extent possible, and relieve the pressure on the great vessels. You can also get fibrosis in other parts of the body, although this is less often described. You can get fibrosis in the lungs, fibrosis in the pleura, associated with bronchial carcinoids, and sometimes even from GI carcinoids. You can get fibrosis of the penis, so-called Peyronie's disease, has been caused by carcinoids. It can cause impotence, and there are urologic procedures that can correct this. You can get skin fibrosis that can resemble scleroderma, and people can be misdiagnosed by dermatologists for the fibrosis in the skin. Although it hasn't been proven by large controlled trials, there's a feeling that using omega-3 fish oil, 1,000 milligrams twice a day, may reduce the extent of fibrosis. It tends to have an anti-fibrosis effect in general. Okay, pellagra has been mentioned a few times. It's caused by niacin deficiency. In America, to get niacin deficiency by not eating niacin is very, very difficult to do unless you have carcinoid. But if you have carcinoid and you don't eat too much protein, and you don't have a large enough supply of the amino acid tryptophan, the little tryptophan you have can get diverted into making serotonin, as was pointed out, and you end up not having enough niacin, and you get pellagra. Okay? Pellagra in Italian comes from words that mean ugly red skin, basically. Ugly skin. And it's caused by this niacin deficiency. Rough, red, scaly skin, soreness of the tongue or glossitis, soreness at the corners of the lips, known as angular stomatitis, mental confusion. And you have to realize that redness of skin is one of the things that comes from pellagra, and not everybody with red skin, as we mentioned, has carcinoid syndrome. Poor dietary intake, diarrhea, malabsorption have been associated with pellagra. And to treat this, you use a high-protein diet and niacin supplementation. Remember, if you take a whole bunch of niacin in one shot, you could end up flushing from the niacin and think it's making your carcinoid syndrome worse. So just to avoid the confusion, take a little dose of niacin, like 25 milligrams, and you can take it a few times a day. There's a condition known as rosacea, which is persistent red, thick skin affecting the face and upper body and can become quite disfiguring. It results from chronic severe flushing, but fortunately for carcinoid syndrome patients, it doesn't usually happen from the small intestine carcinoids, the midgut carcinoids. It's more common from histamine-mediated flushing from stomach carcinoids or other foregut carcinoids. These are the tumors that make the atypical carcinoid syndrome with bright red marginated flushes that are often pruritic. They itch, and they last longer than the midgut carcinoid flushes. They often last for 30 minutes. These are the kind of flushes you get from stomach carcinoids. And people that have severe flushing from this kind of condition should have their disease treated very aggressively before they develop these irreversible condition of rosacea. You treat with octreotide, antihistamine, steroids, tumor debulking to try to prevent cosmetic deformity. What are some other unusual manifestations of carcinoid syndrome? Proximal neuromyopathy. You can get pain in the buttocks, thighs, and shoulders, typically, often misdiagnosed as fibromyalgia or a whole variety of other nonspecific aches and pains. When you get this kind of condition, it's difficult to arise from a sitting position, and it improves with exercise, the opposite of Guillain-Barré. It improves with exercise. And symptoms resolve when you remove the carcinoid in most cases. Diabetes mellitus has to be mentioned. 1 out of 5 carcinoid patients ends up with a diagnosis of diabetes mellitus. And 1 out of 6 patients with pancreatic NETs, diabetes mellitus. So you have to watch out for blood sugar and be aware of the problem. When you use octreotide, lanreotide, somatostatin analogs, they can cause the diabetes in some patients, and they can worsen diabetes in other patients. Populations at highest risk for diabetes include renal failure patients, patients of Japanese descent, and people of African American descent have the highest risk of diabetes in the carcinoid population. How do you prevent diabetes? There are no specific trials that I'm aware of in carcinoid and neuroendocrine patients for prevention of diabetes, but strategies that endocrinologists recommend in general for diabetes prevention would be very reasonable to use if you have a neuroendocrine tumor, if you're taking octreotide or lanreotide. Exercise, 4 hours a day of walking, 4 hours a week of walking or equivalent. Monitor your blood glucose. Watch your diet. Have increased dairy, nuts, whole grains, leafy greens. Try to avoid concentrated sugars, sodas that are made with sugar. Don't smoke. If you have to use medications for cardiovascular disease, you might as well use one that increases a diabetes risk, that decreases a diabetes risk rather than increases it, particularly losartan or Cozar for hypertension, enalapril or Vasotec for congestive heart failure, Provastin or Provocol for hyperlipidemia have all been associated with a decreased diabetes risk. If you get a blood sugar which is greater than 130, you start getting nervous. You try to maintain a blood sugar less than 130. You try to maintain a hemoglobin A1C that's less than 7. avoid getting hypoglycemia, where you have a risk of losing consciousness or having severe problems. And anybody who has a problem with diabetes should be under the care of an endocrinologist who's an expert in these particular things, would be my recommendation. Use oral hypoglycemic drugs whenever possible, but if that doesn't work, insulin is needed, because ultimately insulin deficiency is present in this type of diabetes. And most importantly is the last point. Neuroendocrine tumor patients now live a long time, and vascular complications of diabetes happen if you don't treat the diabetes. So by all means, regulate the blood sugar, and if it starts getting high, follow properly. B12 deficiency is a sneaky and common problem in the patient population that we're talking about here. It results from terminal ileum resection or from having a gastrectomy for a gastric carcinoid. Most commonly, the terminal ileal resection. In order to absorb B12 in the body well, it happens that the absorption takes place in the last part of the ileum after combining with a substance known as intrinsic factor made by the stomach. If you have B12 deficiency, you can get anemia, but most importantly, you can get peripheral neuropathy, which is irreversible in many cases, and psychiatric symptoms, and you want to avoid getting to this point. Okay? It's very easy to diagnose, a simple blood test, and very easy to treat. If B12 is less than 100, you have B12 deficiency. So you get a B12 level. If the B12 level is less than 100 picograms per mil, you have B12 deficiency. If the B12 level is between 100 and 400, deficiency might be present, and you can check methylmalonic acid and homocysteine, and if either of those are elevated, your B12 level is deficient and you should be on therapy. If somebody's already on therapy, they should stay on therapy for life. And how do you treat? 1,000 micrograms IM as a loading dose if needed, and then 1,000 micrograms IM every month as a maintenance. It turns out you can also use high-dose oral B12 to overcome the lack of terminal ileum, and you can use 1,000 to 2,000 micrograms per day orally or sublingually initially, and then 1,000 micrograms as a daily maintenance. So that's another way to supplement B12. The last complication of diabetes, of neuroendocrine tumors, carcinoids, that I'd like to mention is uncontrolled carcinoid syndrome. If somebody has uncontrolled carcinoid syndrome, the first thing you think about is maybe they're not getting enough octreotide, measure an octreotide level, and I know you'll be hearing more about this from Dr. Woltering later. You can use octreotide subcutaneously to supplement the long-acting octreotide once a month to help relieve the symptoms from the uncontrolled syndrome. You consider alternative somatostatin analogs that are available, such as lanreotide or pasreotide, that's SOM230 LAR, an investigational one. Cyproheptadine, 3 to 8 milligrams orally 3 times a day, or 0.4 milligrams per kilogram per day in divided doses. If this is going to work to help diarrhea, it'll always work in the first week. If it doesn't work by then, it probably won't. But it does reduce diarrhea by 50% and flushing by 17%. Before we had sandostatin, this was a standard therapy, and even after sandostatin, if it's not enough by itself, after octreotide or lanreotide, you can go ahead and use this kind of medication. Also, sometimes it's helpful to use anti-serotonin, anti-nausea medications like ondansetron. Brand name is Zofran. There's several brands of anti-serotonin nausea preventives like that. You can use steroid medications like prednisone, 20 milligrams a day for severe flushing that can't be relieved by other means. Opioids for diarrhea, like tincture of opium, can sometimes be helpful. Bronchodilators for wheezing. So you use whatever it takes to treat the symptoms of the carcinoid syndrome in addition to the somatostatin analogs. Okay, thank you. And I don't know if you have time for questions.
Dr. Wolin, and I think we can take 1 or 2 questions. Over there.
Yes. Excuse me? Should you automatically have an echo? I would say that everybody who has carcinoid syndrome should have an echo. I think everybody who has a diagnosis of a carcinoid doesn't necessarily need an echo. If somebody has a 1 centimeter lung carcinoid taken out, I don't think they have to have an echo. Or if somebody has a little carcinoid of the appendix and taken out and there are no symptoms and everything's fine and there are no elevations of any markers, I don't think it's worth getting an echo. I think the yield is going to be essentially zero. But I think anybody who has carcinoid syndrome, anybody who has an elevated serotonin or urinary 5-HIAA, I think it's worthwhile to get a baseline echocardiogram and to follow annually. Yes?
At your comments regarding the incidence of diabetes in the presence of carcinoid tumors, I think the first time I heard this express this way, and there probably is two hormones that are responsible, one being breakdown factor and also glucagon. But most importantly, I think, was your recommendation for exercise. As we all know, the 5 E's of excitement, exercise, emotion, ephedrine, and ethanol turn on. The adrenaline turns on the carcinoid. So Dr. Wolin's use of the Sandostatin sub-Q is perfectly appropriate. You take it 30 minutes before you exercise for your diabetes, and you don't have the response, the hyperrenal response of carcinoid.
Thank you. It's an excellent point. Thank you.
Any further questions? Oh, over there, yes, please.
Yes. How can you follow ischemia on a long-term basis? I think that that's not something that's normally a long-term situation. If somebody develops bowel ischemia, that's really a surgical emergency, whether it's an acute emergency or a subacute emergency. And I think that anybody with a question about bowel ischemia needs to get evaluated very urgently by correct, as Dr. Woltering says, a competent surgeon and gastroenterologist team and an approach needs to be developed and a diagnosis needs to be made right away. So this isn't something where you just get an annual test like you do for an echocardiogram to see if you still have bowel ischemia. Here, Dr. Werner has a comment on this. Correct. Correct. That's also an excellent point, and also something to alert you to this condition is having MRI or CT reports describing large masses at the root of the mesentery, which is a common place to have tumors in metastatic tumors in carcinoid, and this is the place where the mesenteric artery has the most chance of getting squeezed.
I think we had to move on. Just a comment about the chronic angina. And if it's not possible to operate, of course, that is the first thing you should consider in these patients. You can try anti-migraine therapy. This can help in some patients. Okay, I think we had to move on to the next speaker.